To move on now to introduce Josh Gordon, the director of the National Institutes of Mental Health, really the leading federal agency on the intersection of mental health disorders and neuroscience. Josh pursued his MD PhD at UCSF, working with Michael Merznick, or Michael Stryker, really one of the world leaders in understanding sensory function and brain plasticity. He went on to Columbia for his residency and stayed through his early career and into professorship, where he went on to study mouse models relevant to psychiatric disease with really the cutting edge tools of imaging and optogenetics. He's done so many things in that area, from leading the residency program, leading the neuroscience curriculum, and then all of us were fortunate to have him recruited by NIH to help lead the field. We can't think of anyone better to help lead the field into the next generation of the 21st century of psychiatry and mental health and computational neuroscience. Thanks so much, Josh, for joining us today.
Thanks, Carrie. I'm really happy to do so. I'm happy to give you what I think, in contrast to the last talk, it's going to be less about the cool things we can do now, and hopefully more about the cool things we can do in the future. But it's definitely focused on this issue of bringing technology to psychiatry, and actually focused on the theme for today, which is really about computational approaches. Good. Slide advances work. But first I have to start at the mission of the NIMH, which is to transform the understanding and treatment of mental illnesses through basic and clinical research, paving the way for prevention, recovery, and cure. And while we're rather serious about this mission, we're also quite serious about the degree to which technology and in general and computational approaches specifically are going to help us really across the entirety of that mission, both in terms of understanding and in treatment. And hopefully I'll give you a little bit of a flavor of what we're looking forward to from that perspective. The immediate momentary basis for this talk is going to be focused on a particular problem, at least the first half of the talk, a particular problem in psychiatry, and envisioning how we can bring these approaches to bear on that problem. And the problem, of course, is one of the most severe outcomes of, if not the most severe outcome of mental illness, death by suicide. The motivation for this being the focal point, at least of this talk, is shown on this slide, where you can see the rates of suicide climbing over really the past 2 decades unrelentlessly, although we are fortunate just to learn that in 2019, for the first time, those rates didn't go up year by year. And it's partially because of some of the efforts I'm going to talk to you about today that's the case. But suicide is a huge problem, and it's one which you can tell from this graph that we don't have complete control over. And we can imagine or envision how we might bring technology to bear on the problem of suicide prevention. And then at the end of the talk, I'll broaden out beyond that. And when we think of technology, one aspect of what we think about is computational approaches, and that's the one that I'm going to focus on today, in keeping with the theme for today. There are many different kinds of theoretical and mathematical approaches that we can bring to the problems that we're facing in psychiatry in general and to the suicide prevention problem, but I'm going to talk about 3 of them today. I'm going to talk about computational phenotyping, biophysical modeling, and data mining, and just give you a brief examples of each and how they're contributing to our battle against death by suicide. Many people don't necessarily know what I mean when I talk about the phrase computational phenotyping. What I'm talking about is finding a way to break down behavior into its component parts, describe those component parts mathematically with rigor, and then measure and assess them in individuals and relate them to neural activity on the one side and to pathology on the other side. Now, one could reasonably ask, how can you do that with a behavior as complex as suicide? And it's challenging, one can imagine, but I'm going to attempt to do that. I'm going to use a starting point for this computational phenotyping exercise, a decision-making model that's been studied for a long time in neuroscience. Among others, Mike Shadlin has really pioneered. The idea is that in order to make a decision in life, you have a starting point for where do you sit with that decision, and that's illustrated by this black arrow towards the left side of this graph. And over time, you then gather evidence that might persuade you to act in one way or the other. And one can imagine on this graph that I'm showing you that the y-axis represents the decision to go with decision A, which would be at the top black line, or decision B, which would be at the bottom black line. And that time is increasing as one moves from the origin point on the x-axis towards the right. And what you can see here is by this jagged black line that's increasing as one goes from the starting point to the decision boundary, that evidence is accumulating that the best mode, the best decision to make is to go with decision A or action A. This model has been studied in lots of different contexts, but in this context, let's say that reaching that decision point is going to cause the person to make an action, let's say press a button or release a button. And one can easily think of this in terms of sensory decision making. Let's say I'm looking at a scene, I'm trying to count up the number of dots in that scene, and once I know that there's more than 100 dots, I have to press the button, or if there's less than 50 dots, I have to press a different button. And so you're gathering evidence over time. Let's say you're counting up those dots, and as that evidence increases towards the press button A, you will get to at some point to enough evidence that you're convinced that there are 100 dots on the screen. So you're going to press that button. You reach that decision boundary. And again, that's that top black line. The rate, there are several different mathematical constructs or parameters that one can measure or calculate with regard to this decision-making model, which collectively is called the drift diffusion model. You can note the starting point, which can be called bias. It's here illustrated by the gray arrow. You can see that this individual is biased for whatever reason to choose button A. That is, their starting point is slightly above the midpoint. Then there's the drift rate. How quickly do you accumulate evidence? That's that purple arrow, and you can see that the drift rate is, occurs over a certain amount of time. And then there's the reaction time, the time from the point at which you're starting to try to make the decision to the point where you reach that decision. And the reaction time, of course, is a function of the bias as well as the drift rate. So these variables are related to each other. And of course, you can construct a formula that predicts how quickly you're going to make a decision based upon these three factors: the bias, the drift rate, and the reaction time being the solution on the other end. So this is one way you can break down a complex behavior, in this case, decision making. Now, suicide is, in the end, a decision. It is one which is, you could argue, is a pathological decision, but it is nonetheless a decision about whether to act or not. And that decision, of course, is influenced by various, often pathological processes, such as mental illness. But it's a decision nonetheless. And one can ask, is there something different about the decision-making process in individuals who make a suicide attempt, for example, compared to those who have not made a suicide attempt? And so indeed, that's what this investigation by Milner, that was reported a few years back, tried to do. They created a decision-making task in which people evaluate a sensory stimulus in two different types of trials where they're trying to escape a new onset escape aversive sound that's already there. You can see that little black horn is illustrative of an aversive sound, or other trials where they're trying to avoid an aversive stimulus that might come. And the sensory stimulus is an ambiguous one. They gather evidence over time, and they measure how quickly people accumulate evidence and whether or not they have a bias towards or against escape or avoidance. And you do that in a number of individuals who have had a history of a suicide attempt, and a number of individuals matched, say, for age and gender, but also for mental illness, to see whether they have differences in their decision-making processes. And the answer that you end up getting is that on one but not the other of the tasks where you're trying to escape an already persistent aversive sound, people who have committed an attempt to die by suicide have a different escape bias parameter. That is, they start closer to the point of escaping that stimulus compared to controls. So they start out with a bias to act, to avoid, to escape that negative stimulus. They don't start out with any bias to avoid an upcoming stimulus. Now, who knows if this has anything to do with the reasons why they committed suicide, but it suggests that one of the factors that might have led to their suicide is a change or a difference in their basic decision-making processes. And importantly, of course, those processes can be mapped onto neurobiology. So this is one example of what we think are a whole class of potential solutions that can enhance our understanding of mental illness relevant behaviors. Taking a complex behavior like suicide or slightly less complex like decision making, breaking it down to its component parts and examining those component parts for differences between individuals with mental illness relevant behaviors compared to those who are behaving more typically. So that's the first thing that I wanted to talk about. The second thing that I mentioned, of course, is biophysical modeling. When we talk about biophysical modeling, what we're saying is, let's see what we can understand about the brain, model that mathematically, and ask whether that accomplishes say, the behavior that we're trying to model, and whether it might make predictions about how to refine our understandings of how the brain maps onto behavior. So I'm going to stick now for a moment with this decision-making phenomenon, because of course, once you've mapped decision-making into these parameters like starting bias and drift rate, and you can figure out whether there are neural representations of those phenomenon, and then figure out whether those neural representations could actually account for the kind of decision-making processes. Now, we're not yet at the point to be able to fully do that in human beings, although we actually can see in neuroimaging experiments, we can see signs of where in the brain this decision-making processes might be localized. And based on those signs, you can also do investigations in non-human primates where you can look at the biophysical level. And this example by Xiaojing Wang, who is then at Yale, where is an attempt to do that, to map these decision-making parameters onto specific neuronal populations. In this case, that he has envisioned or hypothesized that there might be two different neuronal populations of excitatory neurons, one here in purple and one here in green on the top diagram, that are connected by a single set of inhibitory neurons here illustrated in yellow. And by devising the right sets of parameters between the various synapses connecting these groups of neurons, Xiaojing was able to mimic in a cortical microcircuit the phenomenon that we see in behavior at the level of animals. That is, you can have two different populations, one of which both of which are changing over time, and as input bias from these neurons and from outside sensory sources and from the inhibitory neurons, as that changes over time, one population, this red population, you can see its activity in this middle graph in B go up over time slowly. That can mimic the drift rate. And the starting bias can be the relative difference in activities between these neurons. And so you can use this model not only to ask whether neurons are capable of representing this decision-making process, but then you can also use it to look in the brain, in these brain regions where we think these decisions are being made, for the neural correlates of these decision-making processes we expect to see, and ask, for example, whether they correspond, and not just phenomenologically, but actually quantitatively, with what we might expect based upon the biophysics of the model. So we can break down a behavior into component parts using computational phenotyping. We can then model that in neurons, and we can then ask how those models might go awry in mental illness, and we can map onto that what we know genetically, what we know from environmental exposure, et cetera. We can map onto that what we think might contribute to mental illness. So this is going to be really powerful for understanding. But how do we get to treatment? And what technological approaches might help us, for example, prevent suicide? And in addition to, of course, developing an understanding, and that might lead to novel treatments, we can use these approaches even now to help prevent suicides even without that understanding. And one example of that is work that we've been doing first with the Army, here with the Veterans Administration, and now also with private healthcare organizations, to use multimodal evaluation of patients to identify those who might be at risk. for dying by suicide. And using these kinds of approaches, you can use large data sets to predict tranches of individuals who are at elevated risk. In this dark black line, you're talking about the top 1/100th of 1% of individuals who are at risk of suicide based upon their demographic data, their electronic health records, and some answers to some quick surveys, who are 140-fold increased risk for suicide. Or you can pick a larger swath. Let's say this first solid line with, I think it's triangles, but it's hard for me to see, that are the top 1% of risk, who have about a 10-fold increased risk of dying by suicide. And you can identify these individuals using these AI methods and refer them for treatment and hopefully reduce their rates of dying by illness. So we can see how computational approaches can help us understand, characterize our patients, and also identify those most at risk and affect treatment protocols. And of course, I haven't even mentioned what you've been learning about over the last 24 hours, and that was alluded to in the first talk, that if we can use these technological approaches to develop, to deliver treatments as well. And I think I won't have much more to say about that today. But I want to try to put it all together. How can we integrate these different approaches, and how might psychiatry work in 10 or 15 or 20 years once we have this kind of information about our patients? Really, this process of trying to envision this began some time ago, when we began realizing that if we could group together patients, even with different diagnoses, and get integrated data about them, we might be able to characterize those patients better and use that to develop patient-specific treatments. And this, of course, is the motivation for the RDoC system of characterizing our patients behaviorally, but it goes beyond behavior, and I want to point that out. What really we want to do is take a number of different sources of information, genotypes, phenotypes, biomarkers, electronic medical records, put it into a database, use that database to drive our own decision-making engines that we can then use to guide patient decision-making, and also push that back through the EMR into refining our decision-making processes in our databases. What kinds of information we need? We need biomarker information like EEG, maybe imaging information like resting state functional connectivity, and quantitative behaviors like, in this case, eye tracking, which is used to make predictions about the course and severity of autism, for example. If we can get this kind of information about our patients, that would be helpful. But we also need more of these computational behavioral phenotypes. I'm illustrating 3 here. One is a reward learning, reward acquisition. Another is risk-taking. And then, of course, I told you about the decision-making systems. If we can model more of these behaviors and instantiate them actually in gamified versions that we can roll out in smartphones and the like to large numbers of people, then we can characterize our patients in behaviorally according to these different computational phenotypes, map those onto neurobiology, and ask how much they add to the picture in addition to biomarkers. And so what we envision is using that in large data sets. How large? For example, one of the partnerships that we support at NIMH is the Mental Health Research Network, a conglomeration of 13 health system research centers with 12.5 million people under care, where we have intense electronic record data, and we're already engaged in clinical trials with thousands of individuals done very, very inexpensively through the EHR. We can imagine adding components like biomarkers and behavioral phenotyping onto that. And even larger than that, we can, or more detailed than that, we can use existing structures within the NIH, like the All of Us cohort that aims to enroll 1 million participants with deep phenotyping data to gather the data we need to accomplish this. Finally, we have clinical networks as well that are engaged in care that we can use as learning healthcare systems with this data. And so we envision, again, this future where we have a learning healthcare system that's based upon the accumulation of data of our patients, the building of databases that help us interpret decision engines that will aid clinical decision-making, and on a feedback loop for a learning healthcare system. And with that, I'll turn it back to our mission and turn it over to Carrie for discussion.